Order. Good morning, everybody. I'd like to call the Standing Committee on Health to order this Thursday, March the 14th. This is the Standing Committee on Health, and I'd like to ask by starting that the committee recognize themselves and introduce themselves, starting with Ms. Martin.
Thank you, Mr. Chair. Tammy Martin, MLA for Cape Breton Centre.
Good morning. Susan LeBlanc, MLA for Dartmouth North.
Good morning. Barbara Adams, MLA for Cole Harbour, Eastern Passage.
Good morning. Thank you for being here. Carla McFarlane, MLA for Pictou West and Health Critic.
Good morning. I'm Suzanne Lunas-Croft. I'm the MLA for Lunenburg.
I'm the MLA for Hammonds Plains, Lucasville, Ben Jessom.
Good morning, everyone. Keith Irving, MLA Kings South.
Good morning. Rafa Di Costanzo, MLA Clayton Park West.
Thank you all very much. So today we're here to hear from witnesses regarding systematic changes to our emergency care system. I'd like to remind everybody to please turn their phones off or put them on vibrate. I'll now ask the committee members to introduce themselves for the record by stating their name. Or I'm sorry, our witnesses.
I'm Tim Guest, Vice President, Health Services and Chief Nurse Executive with the Nova Scotia Health Authority.
Good morning, Denise Perrette, Deputy Minister, Health and Wellness.
Good morning, Andrew Travers, Provincial Medical Director for EHS.
Good morning, Larry Cruson, Director for EHS for Department of Health and Wellness.
Morning, my name is Jeff Fraser. I'm the Director of Operations for the EHS system in EMC.
Gary Chapman. I'm the CEO of the union that represents ground and air ambulance paramedics and nurses.
Good morning, Michael Nickerson, business agent and president of IUE Local 727.
Good morning, I'm Paula Poirier. I'm the Chief Operating Officer for EMC and for the EHS operations.
Thank you all very much. Just one reminder that the red light comes on, that's when Hansard will record you. So if it isn't, sometimes we just wait a minute and I'll reintroduce yourself. And I'm Gordon Wilson, I'm the MLA for Clare Digby in the chair. So we'll start with opening statements from our witnesses, beginning with Deputy Minister Perrett.
Thank you, Mr. Chair. Good morning. We appreciate the opportunity to be here and speak on the issues of the systemic challenges to our emergency care system. As you all know, as we all know, the issues are complex and they're long-standing. And these are issues that are challenging health systems across the country. But what we have in Nova Scotia is a very strong foundation to build on, and some very good work on the issue that's gone before us. So you have 4 key organizations here today. We're all working together for positive change on this issue, and I want to briefly touch on each group. IUOE, the union representatives representing paramedics, are here, and it's good to see them. I'm a come from away, and I know from where I come from that we've all looked to Nova Scotia and its organization of community paramedicine and its paramedic program. It is internationally recognized. It is a system of excellence. In working with health professions over the years, it's my experience that paramedics are one of the most progressive and collaborative health professions. I've had wonderful experiences with them. And they are often at the forefront of addressing some of the complex issues in the health system. And we have many examples of how they've done that in Nova Scotia. So I think it is really excellent that we have Terry Chapman and Mike Nickerson here on behalf of their members to provide us with important information that informs the path forward and prompts us to action. We also have EMCI here, and it's glad to see them here. They're one of our partners in the healthcare system, and they have responsibility for managing and operating ground and air ambulance, telehealth, and the Medical Communications Centre in Nova Scotia. EMCI delivers important emergency health programs to Nova Scotia through their staff of paramedics, nurses, medical communications officers, and support staff, as well as ensuring that we have an emergency response system that never sleeps. They are leaders in helping to advance community paramedicine, important programs that ensure our healthcare system is adaptable and agile. Community paramedicine programs see paramedics function outside their traditional emergency response and transport roles to help facilitate more appropriate use of emergency care resources and to enhance access to primary health care. I'm also glad that Tim Guest could join us from the Nova Scotia Health Authority, and I know he's an extremely busy person. NSHA, as everyone knows, is our primary service delivery partner and operates the province's emergency departments. With the consolidation of the health regions, we benefit from NSHA's ability to draw upon province-wide resources and experience to provide and inform care. And NSHA has been very active and proactive on advancing the provincial system of emergency care. And the Department of Health and Wellness is the 4th organization here. We're the policy arm of the system, and we benefit from the leadership and advice of people like Dr. Travers, our Emergency Health Services Director, and Larry Cruson, our EHS Director. The Minister of Health and Wellness is charged under the Health Authorities Act with providing leadership for the health system and setting strategic policy direction and priorities. I can tell you that he has been focusing all of us on the needs of the emergency care system and the current need to address the ambulance offload issue. Over the past number of months, the Minister has facilitated a very collaborative effort that I think has us all well informed, energetic, and very focused on the work that needs to be done. So we know that there are significant pressure points in the emergency care system, but we also know we have the benefit of dedicated and skilled health professionals and managers, as represented here, who recognize the need for systemic change, who continue to step up every day to address the challenges facing the system, and are truly leading change. It is a true privilege to be able to work with these people and organizations. I look forward to the discussion this morning. Thank you.
Thank you very much, Deputy Minister Perrett. Next, we have Paula Poirier.
Thank you, Mr. Chair. I'd like to thank the members of the committee for the invitation to attend today and for the opportunity to speak to the important role that EHS and our team plays in emergency care and the overall health system. We proudly employ over 1,300 paramedics, nurses, communications officers, leadership and support staff. These highly trained professionals work in the EHS system, in the Medical Communications Centre, the Life Flight program, ground ambulance services, and as well in several innovative community paramedicine integrated health programs. In all of these roles, EHS clinicians deliver quality, safe care to Nova Scotians each and every day. EMC, which I'll refer to as EHS Operations, is a Nova Scotia company that has been a proud partner of the province of Nova Scotia since 1997. When we assumed the role of managing and operating Nova Scotia's ambulance service under new standardized provincial emergency response system. Since then, we have continued to grow and expand our role in the healthcare system. The EHS system is highly integrated and streamlined. We work closely with the Department of Health and Wellness and our partners at the Nova Scotia Health Authority, the IWK, medical first response agencies, and others to continuously improve the services we provide. The EHS system is designed to be responsive to ebbs and flows and pressures on the EHS and healthcare system. It expands and contracts based on call demand. Paramedic units fluidly move across communities based on this demand. By design, the EHS ambulance deployment plan is dynamic in nature and is continually moving. Our licensed paramedics, nurses, and communications officers are leaders in their communities and play a vital and evolving role in the healthcare system. They work closely with EHS medical first responders who respond to emergencies in communities all across the province to deliver initial pre-hospital care. Paramedics and nurses respond to emergency calls, providing high-quality resuscitation, critical care, and supportive care. They are there for people when they are most in need. The EHS system is patient-centric, collaborative, and strives to be innovative. The following programs implemented have goals of providing excellent patient care and reducing patient volume in the health system. Paramedics work in collaborative emergency centres, providing care to patients in rural communities, working in collaboration with the Nova Scotia Health Authority, nurses, and EHS physicians. Extended care paramedics in Halifax are caring for seniors in nursing homes, in collaboration with long-term care staff to safely treat patients in their homes, reducing unnecessary EHS transports to emergency departments, which in turn reduces pressure on the system. Through our evidence-based paramedics providing palliative care at home, paramedics have been trained to provide palliative care in comfort of the patient's own home, if that is their wish. And most recently, a community-based paramedic program launched in Cape Breton. Here, paramedics provide follow-up, non-emergency visits in partnership with other healthcare providers, nurses, and physicians. EHS has been internationally recognized for its commitment to pre-hospital care and novel approaches to service delivery. The EHS ground, critical care, and medical communications programs have all been accredited and re-accredited for many years. These independent accreditations provide external validation of the high-quality care provided by our EHS clinicians and how well-designed Nova Scotia's integrated provincial EHS system is. Our clinicians, support staff, and leadership teams are highly committed to providing Nova Scotians with high-quality and safe emergency, critical, and supportive care. As we know, there is a definite strain on the healthcare system and on emergency care, including extensive emergency department offload delays. Our leadership team is adjusting and fine-tuning the EHS deployment whenever possible to ensure emergency coverage. EHS clinicians are working very hard to provide care, respond to calls, and provide coverage in this demanding setting. Due to offload challenges, paramedics are at times spending their entire shift waiting in the emergency departments with limited breaks, increased overtime, and provider fatigue. EHS operations have implemented a number of initiatives to help alleviate some of these challenges, adding unit hours within the system, increasing the paramedic staffing numbers, collaborating with the Health Authority for policy that directs low acuity patients to care for and be transferred to triage staff, and we refer that as Director Chair's policy. Adding a dedicated transfer coordinator to the EHS Medical Communication Centre to improve efficiency of patient flow and EHS transfers, and redesigning the operations leadership model to ensure more support is available for staff, putting an internal hours of work policy into play to help ensure patient safety and staff well-being. I'd like to re-emphasize that EHS Operations is fully committed to working with our partners at the Department of Health and Wellness, Nova Scotia Health Authority, the IWK, and as well, obviously, as IUOE, to help implement solutions to help improve the emergency care and patient flow. We work closely and collaboratively with the Health Authority in the coming weeks to implement strategies to transition the care of our patients from our paramedics to receiving emergency department clinicians and other health staff. These strategies will improve patient care and safety for transport EHS patients and will enable paramedics to clear from emergency departments quicker and return to service in order to provide emergency coverage and response. We are confident these solutions will bring immediate relief to the EHS system, and we look forward to working with our partners to help position the healthcare system for success. On behalf of our team, I want Nova Scotians to understand that even with the high pressure and demands on the EHS system and the healthcare system, they're covered. When help is needed and people call 911, an EHS paramedic crew is dispatched immediately. EHS communications officers provide directions and support to callers on the phone while paramedics are responding. Those who require the EHS system for emergencies will receive an EHS response. EHS paramedics, nurses, communications officers, leadership, and support staff work very hard each day within this busy and complex system to provide excellent pre-hospital and critical care to Nova Scotians. We would like to thank and sincerely thank all our staff for their continued support, commitment, and dedication to the EHS system and the patients that we serve. Thank you for your time.
Thank you very much, Ms. Poirier. Next is Mr. Chapman.
Good morning. My name is again Terry Chapman. I'm the CEO and business manager of the union that represents ground and air ambulance paramedics and registered nurses. With Ms. Poirier's opening comment, it doesn't leave a lot left to the imagination. But I'd like to first of all thank everyone for the day, for the opportunity to be heard, and for the opportunity for our members who are the paramedics who turn the wheels and help unwell people in their daily issue and ongoing through their life issues with their families. That the issue for us has always been, since this program started in 1995 and 1997 with EMC Medical Care Incorporated, our issue has always been that we need to understand that safety and wellness is the driver for all of the people every day. It's not simply something that we can go to work and be unwell and unsafe on one day and then say, okay, it's okay to be unwell and unsafe on Wednesday because Thursday is going to be better. Since the issue, as we understand it, with offload delay and all of the fallout from that, the overtime, the missed meals, and by overtime, when Paula spoke to spending an entire shift in a hospital, that also leads to 4 to 6 hours overtime after release and getting home to where you started the day. Paramedics are missing their meals. They're routinely not at home when they should be. They have family commitments. And our position in this with the fellow and sister stakeholders is that we all recognize that we need, as a group, and this body in this house, we all need to fix this. It's nice that we can have standing forums, and we do appreciate this very much. But recently, with the health minister committing to work with us and showing us that by inviting us several times, it gives us some hope that there will be a remedy to this. But the remedy needs to be driven, and it needs to not be delayed. Our members on a daily basis are fatigued to the point where they just go home, and some of them don't want to go to work again. When some of the members, and being the ones who have more of a committed history with the employer as a paramedic, I realize it's their job to be a paramedic, and it's their job to sometimes have inherent overtime. And they realize that sometimes they won't be home to pick up their children from daycare now and then. But this isn't what they signed on for. And this isn't a program like others where there's a guaranteed point of wellness at the end of the day. And most people, and no disrespect to those who can, go to work, they get a break, they get a lunch break, they eat their food, they go back to work, and they go home. They're not hungry and malnourished for the day and overtired from the day before. And Mr. Nickerson and I are here to hopefully answer any questions we can and impress upon your committee the need for this and the need for wellness. And within the total scope of the 4 combined units, there are, I guess, stakeholders in this within the province. Our position and our responsibility to some people seems small. We have, excuse me, the position to represent not just the day-to-day union, give us money, give us time off, give us vacation issue. This for us is not only a program that causes unwellness as it's run now, but publicly we've also stated that it's, in our opinion, also a public safety issue. And when you can't get an ambulance to a person who needs one, in the amount of time that in 1997 was directed at being approximately 8 minutes and 59 seconds, and now it's hours in some cases, that's a public safety issue. And it needs to be addressed. And again, our position, Mr. Nickerson's and my position, in this, the union position, seems small in the grand scheme of things if you look at the numbers and the values of all of the components of the stakeholders. Because we only have a concern for the wellness component and for the public issue. And the other concern, while we do have the offload delays, specifically how it's not maybe functioning very well, that's not our forte. That's what we rely upon all these other people for. That's what we hope you people will help direct. And even though our number is small and we look after about 1,000 people as members, and what I meant by our issue is small, sometimes it's looked at, well, you're not the big fish in the pond. If you're looking at offload delays across the province and the hospitals and the systemic issues that cause offload delays, then out of 1,000 people who turn the wheels and pick up sick and injured people, to us, that's a small number, but to us, it's not small. It's no smaller than any other of the components that cause the issue. So, having said that, I'm hopeful that somehow through the event today and working in the future with government, with other stakeholders, Mr. Travis's programs, the employer, EMC Medical Care Incorporated, that we can all become one fix to a problem that is critical. It's systemic, it cannot continue, and it's going to reach a critical mass, and people are going to suffer from it. So having said that, thank you, I'm appreciative of being here.
Thank you very much. Excuse me, thank you very much, Mr. Chapman. Mr. Nickerson.
Thank you, Mr. Chair. Committee members, fellow witnesses. My name is Michael Nickerson, and I'm the president of IUE Local 727, the union that represents Nova Scotia paramedics and life flight RNs. Before that, I was a paramedic for 18 years. I know what our paramedics are facing, and it's time we work together to find a solution. Paramedics in Nova Scotia are some of the most highly trained and skilled paramedics in North America, as we heard from Ms. Poirier. They should not have to wake up in the morning and face the constant risk of missed meals, back injuries, shift overruns, and offload delays. Our paramedics are incredibly adaptable, and they're doing the best that they can in a broken system. But enough is enough. Paramedics are tired, they're hungry, they're feeling the pressure of a busier and busier system that they work in day and night to keep our communities safe, and they aren't getting the respect that they deserve. We don't pretend to have all the answers, and we know that there is no quick fix to this problem. But we also know that something needs to be done, and it needs to be done now. We have asked over and over again for a meeting with everyone involved to try and find a solution, and that still hasn't happened until now. Thank you for having me here today. I hope that what I have said really resonates with you, because something desperately needs to be done, and the solution won't be found behind closed doors and hushed meetings. Thank you.
Thank you all very much for your opening statements. We'll start with 20 minutes per caucus, and we will try and wrap up about 11:50 if we can. So opening up with the Progressive Conservatives, Ms. Carla McFarlane.
Around 11:50 or 10:50?
I'm sorry, 10:50.
Yeah, I would love to have 11:50.
I don't want to get you guys going.
Should have asked for clarification.
Couldn't sneak that one by, could I?
Look, welcome. Thank you for your comments. We are listening. They are meaningful, and there are good things happening in our healthcare system. We don't deny that, but we definitely are here today because there is a crisis happening in our emergency rooms. And I think there is one common denominator, though, that we can all agree on, and it's that we want to fix it, and that we are concerned for public safety. And we can't delay this any further. We really, really can't. So with going forward with questions, I would like to start actually with Mr. Chapman or Mike Nickerson. Feel free to either one of you to answer. But, you know, we have been paying close attention to what's happening with Code Critical, the campaign that's on social media. So I'd just like us to know a little bit more of when did this start? The campaign was initiated for what reasons, and what are you actually trying to highlight? And more importantly, what would it take to end this campaign?
Mr. Nickerson.
Thank you. Thanks for the question. So Code Critical started a year ago, this past February. And it was to bring highlight to the lack of available ambulances in certain areas throughout the province, just to make the public aware, because like we say, we view it as a public safety issue. And our hope was that the public would go to their elected representatives and have the discussion with them to bring it to the floor of the legislature and try and find some remedies. To end it, I guess we need to start having discussions as we have been saying all along. So today's a good start. We're going to keep Code Critical going though, but if we can see some definitive results or action being taken by the government that will fix some of these issues, offload delays, and the inherent shift overruns of our members, then Code Critical may cease, but it's not going to anytime in the near future.
So what would those conditions be in order to ensure that Code Critical would end?
Well, I think as long as the public safety is looked after and that there is available ambulances where they're supposed to be throughout the province, that would be when we would cease Code Critical.
So are you indicating that we need more ambulances and more paramedics?
In the interim, absolutely, we do. I don't think that's a long-term fix. I think that's a short-term. But we do need that for our members because of everything that my colleague had said earlier. You know, our medics are they're run off their feet. They're missing meals. They're getting inherent overtime, shift overruns, anywhere from an hour to 6 hours. And it's just not safe.
So I know that for the last few months, daily, I have heard from paramedics across this province. I actually apologize to your members because I can't keep up with actually responding. And I feel very guilty about that because I usually get back to people within 24, 48 hours, and now it's taken a few days because the requests and calls and emails from your members are very concerning. And I feel deeply for them. I can't imagine being a paramedic in a situation where you're standing in a lineup of 15 ambulances waiting to offload, and because I know they deeply care, and they're there to fix situations. They're there to help, and that's how the public views them. And they're standing there, and they know there's other calls coming in that they can't get to that actually may be more critical. And we all know there has been situations like that. So with you having the opportunity, though, to speak to paramedics daily, and to many of them, what are they telling you is the actual root cause of this crisis?
That's a multifaceted situation. I guess the lack of acute care beds in the emergency departments, the offload delays are probably the #1 issue that is causing all these other issues. And I honestly think if we can fix the offload delays somewhat, then a lot of these other issues that our members are facing will fix themselves.
So acute care beds, long-term care beds as well, would you say, plays a part in that?
I would think so. I'm not an expert in that by any means. Somebody else might be able to answer that, but I think that long-term care beds would help, because then you could move patients out of the emergency department up to those floors that have patients that are waiting for long-term care.
Okay. What about, is there, we know we have a shortage of doctors. I know in Pictou West we have a big shortage, and I don't have a doctor, my children, my father, there's many of us that don't, thousands actually in Pictou County that don't have a doctor. So we hear quite often too that this could be a solution. Do the paramedics feel that that would be a solution, that, you know, more doctors as well in the emerge?
Yeah, absolutely. I think any access to primary health care would definitely help the system for sure. If people could get into a family doctor or a nurse practitioner, then they're not going to the emergency room. I think there's a lot of people that go to the emergency room that probably do not need to be there, but like you say, have no access to primary care.
Mm-hmm. And as well, we recently heard that perhaps we need to ensure that there's nurse practitioners in our emerge. Would that be something that would also alleviate some of the struggle within emerge departments right now?
I would think so. I'm not really familiar with the nurse practitioner.
Okay, thank you. With regards, what kind of burden do you see is the lack of fall prevention strategy putting on paramedics? I often hear from paramedics with regards to fall prevention.
That might be a question for Mr. Fraser or okay. Mr. Travers.
Sure.
Dr. Travers.
Dr. Travers?
With respect to patients and falls or providers and falls? Can I help?
Patients.
I think it's one of the examples of one of the innovations we have in Nova Scotia is a falls referral program. We applaud the communities and the health authority for enabling paramedics to make referrals to a local falls clinic that occurs in the Truro and the Bridgewater area. And that's the illustration of some of the innovations that we're trying to create for seniors and those patients at risk of falls. And I think those types of examples could be applied in other areas of the province.
So that situation in the accreditation report was seen as a failure. So what are we doing to improve that, though? It's actually major high priority in the accreditation report. So what improvements are we making with that?
I'm sorry, I'm not familiar with which accreditation report.
The standard set emergency department. I can table it actually.
I have a copy of it.
If you would like a copy of it.
No, I've got a copy right here.
Okay, great. So it's with regards to increasing a coordinated approach for fall prevention and ensuring that's implemented. So I'm just wondering, have we made improvements with that?
I respectfully probably direct the questions towards the NSHA as it's a reflection of the ED accreditation standards.
Okay. So could someone answer, what changes or improvements are we making with that?
I'm sorry, I was passing a paper. Who did you want for a witness?
Mr. Guest, please.
Mr. Guest.
So certainly we've made a lot of effort to deal with any of the recommendations that came out of the accreditation process when we were surveyed last time. And we've reported significant data back to Accreditation Canada on our achievement. I think it's worth noting that any of the activities that we do related to falls and our survey wouldn't have any implication related to the ambulance service. They would only be reflected on any fall-related activity that would happen within one of our facilities.
Okay, thank you very much. I'd like to go back actually to Mr. Nickerson and Mr. Chapman. I'm just curious, are we seeing a gain in paramedics over the last few years or a decrease in paramedics?
Mr. Nickerson?
I believe we're seeing an increase. Again, that's probably a question for the employer, but I think we're seeing an increase in paramedics.
Great, okay. And I understand paramedics do not have coverage for the same benefits as a lot of other healthcare workers. And I'm wondering if you can explain the difference and difference compared to other provinces.
Mr. Fraser? I'm sorry, Mr. Chapman.
Yes. Could you be more clear with the question in that they don't have benefits equal to?
Well, I understand that they have to pay out quite a large sum out of their pays to have coverage for their own health care and long-term disability, short-term disability.
Through a Manulife program, yes, it's a employee pay program.
And others co-share. I'm just wondering, is there concerns from your members with making changes to that?
Yes. More recently than in the past, they have to us posed the question, what can we do about this and what can we do with this? And the question, I suppose, is spawned not more recently reflects a decrease in their pay or in what they assume should be their pay. And in part, the reason is that with the cost of working and the cost of that program, the Manulife program, which would be any other program, $270 to $300 a month for some people. When we worked it out, Michael and I worked out statistical value to one paramedic's pay over a 2-week period, and then bridged it over several other periods. And it turns out that if you actually make a comparison and into the cost of healthcare, cost of that program, where it increases on its own annual basis of up to 21% each time, that if you want to look at it like we do now, paramedics are paying to go to work. So the question is more prevalent now, and to ask, do we actually have plans to approach that? It hasn't been tabled with anyone yet, but because of the need for it and because also the need for wellness, and there has to be some bridge program, I've committed actually to our members in general, and Michael and I have had discussions on perhaps in the very, very near future that we'll look at what programs are available as bridged programs that are equal to or sufficient for, that don't cost as much money or that can be funded otherwise.
Okay, thank you. With regards to the availability of ambulances, I've also heard that there's concerns that sometimes they feel that they're a taxi service, that they're transporting individuals who are going from perhaps a long-term care facility to the hospital for dialysis, for a checkup. I'm just wondering, do you believe that there's an opportunity for this, for us to change that immediately and create a system where we find, we don't want to say a taxi service, but perhaps we find another means to transport them so that we allow the availability of ambulances to be there for obviously those critical calls that are coming in?
I think any time that you can allocate an ambulance to a more proper service, and to be fair, Mr. Fraser and I, way back in early 90s, worked together. I am a career paramedic and have been one for a very long time. And actually, Mr. Fraser and I worked at the same ambulance service. So we both understand that on any given day, there will be what people can assume to be perhaps the taxi service component of ambulance work. But if for those persons who are not critical or who are not emergent for any other reason, if they had a service that didn't impact the system status of emergency services vehicles, I would have to say that would take the load off. I would be, I guess, compelled to also make the comment that that does not mean that I support privatizing ambulance taxiware.
Absolutely. Okay, thank you. And with regards to, I realize there's a pilot project happening in Cape Breton. I'm just wondering if perhaps Paula, I remember your first name, not your last name, sorry, if you could maybe give us an update on that and how it's working, and when do we plan to implement that across our province?
Ms. Poirier?
Actually, I'm going to pass that over to Jeff here, actually, from the operations perspective. He'll be able to articulate that for sure.
Mr. Fraser.
Thank you for the question. So we began our program in Cape Breton in around the 11th of December, and often as we do with new programs, we do them as a phased approach. These programs have to be patient-centered. There's not a lot of books you can take off the shelf that tell you how to design them, and they have to be built in partnership. So we're in phase one, where we're taking referrals from the emergency department in Cape Breton Regional, and we've just re-engaged with our partner at the Health Authority this week. They're ready to begin the discussions about moving the program into the next phase. All these specialized programs that we've put together, the history has been we've built these in phased approaches. You put them in place, you look at them, make sure they're hitting the mark, make the adjustments you need to make, and then you build on putting in the next one. So although sometimes we certainly like to do things faster, but to be patient-centered, it's important that we take our time as we move through these cycles.
With the implementation of that program, did you have to hire more paramedics for this to be initiated?
Yes, we did. So we hired existing paramedics in Cape Breton. Is one of the nice things about doing programs like this, because it provides paramedics options that they didn't have before. So as Mr. Chapman alluded to when he and I started many years ago, there are very few options for paramedics programs to get into. So we hired from our existing ranks, and then we'll obviously be backfilling those positions.
Okay, thank you. I'm wondering if someone could answer, probably with EHS or DHW, what is the status of the Fitch report with regards to sustainable emergency care? I know that I believe it was supposed to be due to be released this winter, and we haven't seen that report yet, so we're getting a few calls with regards to that.
Deputy Minister Perrett.
Thank you for the question. The Fitch and Associates report is an important part of how the minister is responding to this issue. He wants a very detailed analysis of how the system is working and recommendations from the experts in the field. That report, I think you'll see it in spring of this year, and the work is ongoing. We've seen them very active in both the interviewing and the reviewing of data in the system, so I think it will be an important initiative for the people of Nova Scotia.
Okay, who's actually working on the report? As you indicated earlier, you have 4 organizations here today. Who's actually working on that report?
So the report is commissioned by the Department of Health and Wellness, but Fitch and Associates, in compiling it, then works with all of our associations to do interviews and has collected the data to do a thorough analysis of that.
Okay, thank you. I know my time is running short, but I feel I have time for one more question. I'm just wondering if you can give us some background on the ECP program, the Emergency Care Practitioner. Where is it currently based?
Mr. Travers.
Thank you. I'm very excited about the Extended Care Program. It's an initiative which saw over 920 patients in the calendar year last year, and in 90% of the patient contacts kept those seniors safely at home in their long-term care facilities. At present, it's mainly structured out of the HRM and the partnership with the Infirmary, Dartmouth General, and Cobequid, and the long-term care facilities that feed into those areas, but it's only in the central zone of the province.
So when are we planning to expand beyond the central zone?
An excellent question. Again, following Mr. Fraser's recommendations that we build things in pieces, and as we develop those partnerships and networks of care, we can begin to roll those types of programs out. So keen to continue those conversations with the health authority, but where those hot pockets are to enable programs like that to exist.
Will we see any extension of this program within this year elsewhere in rural Nova Scotia?
As a physician, I always hope so. I always like to start tomorrow again, but the example being is that a phased approach, it does work well.
Okay. Thank you.
Thank you very much for the questions. We'll now move to the New Democratic Party. Ms. Tammy Martin.
Thank you so much, and thank you, everyone, for being here. I'll start with my questions to Mike and Terry, and as from one union leader to another, I'm so happy that you are getting a voice to your concerns. So thank you for being here. A few things I'd just like to clarify from your last remarks, and I believe it was you, Terry, that said paramedics pay 100% of your medical. So as a former NSHA employee, we paid $65.35. So are you saying that there's no co-pay from your employer?
Mr. Chapman.
Not right now. But as I made comment, we do intend to, when it becomes an official comment to the employer, inform the employer that we will be looking perhaps for some bridge program or other program where that's no longer the case.
So sorry, Mike?
Mr. Nickerson.
Just to add to that, the 100% pay is for short-term and long-term. The medical plan is paid for by the employer.
Okay. Okay, thanks for clarifying that. And I believe, Terry, also you talked about, and I completely agree, we don't want to privatize any service, but in my years in the Cape Breton District Health Authority, we had PTUs, which is called patient transfer units. Are they still out there for the non-emergent transfers?
Yes.
Do they ever get used for, or my understanding is sometimes when we are at a code critical point, they are used for other than just transfers?
I think if you want the details or the specifics of that and how they're allocated, when there is the requirement, I think that Mr. Fraser would best answer that.
Okay.
Mr. Fraser.
Thanks for the question. So we have, in our 2 cities in the province, we have what I would refer to as a split production model. And that is, we have emergency ambulances in Halifax region, and we have emergency ambulances obviously in Cape Breton, but we also have these transfer units that you suggested. For the most part, the transfer work that we do is very predictable. We usually know by 4 o'clock today what our volumes are going to look like tomorrow, and allocating those crews to those vehicles which were not part of our emergency deployment plan allows us to move those patients freely between the hospitals. There are occasions, because some of the units we have are multi-patient transfer units, and they have the ability to transport 2 patients at one time. So we like to use those units if we have a major event where we're able to move the ambulances to. But for the most part, we have a split production model, and it is separate, and we do that on purpose so we can take some pressure off the emergency system.
Okay, thank you. So, and back to Terry and or Mike, do you see this code critical as just one result or one systemic issue as a result of the overall healthcare crisis in this province?
I think we understand it as everyone else sees it. Everyone sees that who speak with us, the people who see the code critical issue see it as the issue that might affect them. And perhaps it could be a fair statement to say that not everyone understands the intricacy of the models that need to be refined to cure it. And it's easy to stand outside of the fence and look in and see all of the animals, but it's different than going in and being one of the animals. And we are but one of the animals in the farmyard with all of the other ones, no disrespect, that all need to play together and play nicely and think and learn the program together and then come to a solution to it.
So to that end, I would suggest then that on one of my last tours of the regional hospital ER in Sydney, when there were 27 admits, and numerous patients waiting for transfer to a long-term care bed, and 5 ambulances lined up in the bay, that had we had a significant investment in long-term care beds, then that would move the process through. Because when there's a stall and you can't get patients moving, we can't get our ambulances in and out of the system.
I think that the question of long-term care beds and whatever facilities might be constructed to put those in, that in any way that you can take the load from the ER and get it out of there so that there are available beds in the ER for our members to leave a patient behind and again get back to the street. I think anything that would fix that would be at least a partial cure to it, whether it's long-term care beds or not. And if long-term care beds, and again, Michael and I not being the authority in that or the principal for that, if that's a way to fix it, and it will be fixed, then I'm good for anything that anybody can come up with fixing it.
So how long typically does it take to get an ambulance?
That depends on the day, and all I can tell you is because we don't see the daily CAD stats, we don't actually get that printed into the day that shows where they're muddled. We have a different procedure. But in 1997, when the performance-based contract was devised, there was a township requirement of 8 minutes, 59 seconds from the time you pick up the phone and actually talk to someone until the ambulance is knocking at your door. Now, that could be in cases that we actually have seen, and one case that I actually witnessed was in this city was 58 minutes.
Is that acceptable?
To me, it's not.
So, being from Cape Breton, I have known many instances where there has been 0 ambulances available in CBRM. I also know that sometimes the nearest ambulance is in Badek and or Antigonish. If that was my family member who needed an ambulance, let me tell you, you'd hear me screaming from the rooftops. So what happens when I call an ambulance, God forbid, in New Waterford, and the nearest ambulance is in Badek?
You wait.
So my loved one has just had a cardiac arrest.
You wait with a person who will be probably non-living when they arrive.
And how that doesn't infuriate the people of this house boggles my mind each and every day.
I agree with you.
Do you see any other statistics that would be beneficial to post or publish as with the code critical?
One thing that we're very cautious of is we fully intended to make the public aware every time that we can be aware when there is what we call a code critical issue. And one of the reasons, just to go back a little bit, is when we met with Minister Delory a little over a year ago, when this was becoming the issue, we shared with them that we would like to see something started. We'd like to see some movement in somehow to alleviate this problem. And failing that, we would have to have the public help us do that. People who pay taxes do that. And that's actually what started the Code Critical, is to make the people who pay taxes aware of the probability that there may not be an ambulance when they need one. And by the way, 1,000 of our members pay taxes.
Absolutely. I'm sorry, I'm still upset by your previous answer. The John Ross report in 2010 said that the average, or that the standard patient should wait is 20 minutes. How often is this happening?
I can't give you a brass number on how often it happens because, again, we don't see the CAD at minute by minute. But based on the fact that on any given day in this city there is one available ambulance, I would bet dollars to donuts that it's not very often.
Are the offload times different at different facilities, different hospitals across the province?
Yes.
And why would that be? Is there a reason why certain places are having more of a difficult time to meet that standard, or to even show up within a reasonable amount of time?
Well, one of the things I became aware of at a meeting with the minister, I believe it was on the 8th, was I wasn't actually aware until that meeting, because there were other stakeholders, actually people from the Dartmouth General Hospital were there, and they made me aware of the differences between taking from core staff to facilitate a program and having to otherwise administrate staff, take them in, similar to us moving trucks around inside of the hospital. So I can't answer what would fix it or what the reason in each place is, but each hospital that experiences it, to my knowledge and our experience, that it's never a schedule. You can't say that 9 o'clock this morning it's going to be the QE2, but at 11 it's going to be the Truro, Colchester Regional Hospital. It's random, sporadic, but it does happen every day somewhere.
And you mentioned the lack of, well, one, shortage. A quick fix would be more ambulances and more paramedics, and this government tells us, you know, or has told us in this House that they're investing in, but we believe as well that that's not the long-term fix. I've had conversations with Mike about paramedics fleeing Nova Scotia because they're like other healthcare workers in this province right now. They're exhausted.
That's true.
We have, you know, I talked to many from a cleaner to a doctor and everybody in between, including paramedics, that are exhausted and are not being listened to. Do you have any hope or belief that there's going to be a remedy anytime soon so that you can get back to your families, so that the nurses who don't get a chance, and I quote, get to go to the bathroom on a 12-hour shift, that this will change anytime soon?
I'm hopeful that seeing what's happening today and in the past few weeks with Minister Delory and his folks and Department of Health and EMC Medical Care Incorporated, I'm hopeful that this is a point where we're going to start to see what we would call a corrective resolution to the problem. But I can also see, as was in several years ago, I can also see people who might otherwise have stayed not wanting to be a paramedic anymore and going to other provinces. And when it happens, I've actually jokingly predicted it's going to be June or July of this year, without them actually telling it, because we see patterns. When it happens, it's going to happen, and when one leaves, the people who see the green grass are going to leave with them.
Thank you. So perhaps going back to Mr. Fraser, do you know how many times an emergency vehicle is used as a PTU?
Mr. Fraser.
Thank you for your question. Part of the current system design that is in place, you know, some of those patient movements are utilized by our emergency ambulances. That's the system design that we've been operating on for a number of years here in the province. And it's also one of the reasons that we're very thankful the department has brought Fitch & Associates in. As an operator of the system, obviously we see opportunities to make some major changes. Fitch will help articulate that and help with some of the blind spots in the way that our service operates. So we do recognize this is a great opportunity as we go forward, but ambulances do patient transfers. That is how the system has been designed. In our busier areas, as I mentioned earlier, we do our best to split that volume out. Those hospitals are close, and that's why we have that service in place. But if you're in a smaller area, you may be assigned a transfer, but it's important to understand that we are moving our system around, as Ms. Poirier stated earlier, all the time.
So in the last month, you wouldn't know how many times a PTU has been used as an emergency vehicle?
How many times a PTU has been used as an emergency? I wouldn't have that stat here today, I'm sorry.
No, okay. So to Ms. Poirier, if I could, in your opening remarks, you mentioned strategies and solutions are being developed for the not too distant future. I wonder if you could explain and give us some details on these solutions.
Ms. Poirier.
Sure. Thank you for your question. We have been having discussions, obviously, with the Nova Scotia Health Authority. As you know, from us, from an emergency care perspective, by the time we get to the hospital and the paramedics are standing there, then, you know, obviously we're having to collaborate on what are some of the solutions could be moving forward. Because at the end of the day, if we can move our paramedics out of there, 20 minutes or less, it certainly would make a huge difference for us within the system. As far as strategies and opportunities, you know, I'm going to actually pass it over to Mr. Guest, because obviously they will be the ones that will be leading it. We will be obviously helping out.
Mr. Guest.
Thank you for the opportunity to provide some information on some of the work we're doing. I'll give you maybe the easier way to respond to is to give you a couple of examples of some of the things that are underway. At the Dartmouth General Hospital, as an example, we've implemented a team that takes handover of the patients when the ambulance comes in to allow them to offload and return to the community. It was initially done as a pilot, and it has been really very successful. And so we are expanding that to the Truro site. Sorry, I apologize. We're expanding that to the Valley Regional site in Kentville. It's just started to be operationalized. We've also put in place rapid assessment zones in a couple of sites. Initially, it was put in Valley Regional, and a rapid assessment zone is an area of the emergency department that you move the individual around depending what's going on. So if they are waiting for lab or diagnostic imaging results, they may wait in a waiting area, and then so they don't hold a stretcher up the entire time so that you can get more people through in care. And so we also have one of those at the Halifax Infirmary, and we're expanding it to 24 hours a day to help with our offload issue at the Halifax Infirmary. There's also a rapid assessment zone we're planning for the Truro site, as an example. We've also implemented triage protocols where nurses, when individuals come and assess them, can automatically order lab and DI tests right from triage to help with the timeline and timeliness to care, so that when the physician sees them, the results are already back. I think it's important to say that these strategies are very much focused on the emergency department, and that they won't solve this issue on their own, and that there's a need to focus on reducing the number of individuals that we're caring for in acute care hospitals that would be better cared for in other settings. And so we're working closely with colleagues in long-term care and home care, and also with the Department of Health and the Department of Community Services to improve our processes so that we can maximize as many opportunities as we can for those individuals to be cared for in more appropriate settings. I think the reality of this is it's going to require a systemic solution to a very complex problem that can't be solved by the ambulance provider or the emergency departments alone.
Thank you for that. We know that transferring patients is an issue. Moving patients through the system is a problem, and it's been mentioned and in the accreditation report. We've heard it from patients and we've heard it from doctors. We know that the emergency rooms are backed up, so I'd like to talk to Ms. Perrette about how we can address this issue. Can you tell us, please, about the Home First philosophy and how it's applied in emergency rooms? And would it be fair to say that there are many individuals in ALC who would not be able to go home, who need to go to direct care or residential care facilities that cannot leave the hospital otherwise?
Ms. Perrette.
So it's an important question, and I think the issue of the movement of patients throughout the system is obviously very complex. If it were simpler, we would have resolved that in this province, and we would have resolved it in every other province that is wrestling with it. So what we've been looking at are what are the factors that affect the movement of patients, and what are sort of the levers that we can pull that relieve those pressure points and facilitate the proper care. And there are a number of them. So I know you've mentioned a few, but I don't want anyone to leave. But if it was as simple as having more long-term care beds, then that would have fixed the system decades ago. Because this is not an issue that has risen in the last couple of years. This is an issue in healthcare systems that really has the focused attention of a lot of experts. So we've done a couple of things in the hospital. So first, the minister, as you've heard, has called people together to really focus them on the issue of patient transfer from the offload point and to talk about proper staffing. And you'll see an increase in the funding that's gone into emergency departments and emergency health services. The government's also made a significant, over $8 million investment in a hospitalist program, because hospitalists look at inpatient care and start planning for discharge the minute that patient comes into care. And that discharge planning is critically important. We have long-term care beds that are expanding. You've got the announcement in Cape Breton of 2 new facilities that are being organized. And from what we know in the continuing care system, and continuing care operates in 3 layers, because we have home care, we have care in the community, and an institutional program in long-term care. People tell us that they want to be at home and they want to be cared for in the community first and foremost. And that is the focal point. So there's been an investment in home support, and we are very much focused on how do we support people at home, how do we support the caregivers that are looking for them.
Order. I'm sorry, time is up. We'll allow you to get back to that questioning on the next round. I'll now move to the Liberals with Mr. Keith Irving.
Thank you, Mr. Chair. Perhaps the Minister could finish your answer to the question before I proceed.
Ms. Pratt.
So to finish it, I wanted to inform the committee that there's a number of initiatives, certainly on the home support front, for both people that are being cared for at home, but their caregivers, and a number of interesting pilots that have been done to provide equipment, to provide virtual care. We want to support caregivers through mental health supports because they have anxiety and depression. And we're looking at the linkages where we support people at home through community organizations, and even the linkage into long-term care, so that if you look at modern systems of care, they're looking at how their food services, for example, can provide a food service to people in the home. And so it's one of the most interesting areas in healthcare, and there's a lot of focus and research and planning and piloting going on there. So I wouldn't want anyone to think that no one's paying attention to the issue. And it's just the opposite. They're very focused on how we make this, how we facilitate these transfers.
Thank you. Mr. Irvin.
Thank you, Mr. Chair, and I would like to thank all 8 of our witnesses here today to join us and to discuss this important project. Obviously, this is an issue. Obviously, this is an issue that all Nova Scotians are aware of, concerned with, all members of the House as well, as is the Minister and the Department. So I think this is a valuable session for Nova Scotians to hear of the work that is going on. And I want to begin my first question to DM Perrette. You mentioned in your opening statements that you felt that we had a strong foundation to work towards a solution here. I wonder if you could expand on that.
Ms. Perrette.
Thank you. It's in reference to some of the things I was just commenting on, but in particular, if we're looking at emergency department pressures, if we're looking at the offload issues, we're also looking at how we divert people from emergency care, how we have a system of really comprehensive primary health care in the community. And one of the foundations that Nova Scotia has, and I can't emphasize enough how many people around the world are watching this, is its ability to stand up community paramedicine programs, to provide care for seniors in their home as well as in long-term care, to provide for fall prevention programs. What we're piloting in Cape Breton is an example of how we can use that kind of program and talent to facilitate with early discharge. And we're working with other health professional groups as we do it, because we don't want to have fragmented response systems. So I think that there's really a strong base, and where we have seen, we talked about the extended care program succeed in Halifax, the next place where we're looking at scaling and spreading that, and discussions have initiated, are in the Cape Breton community. So we want to take what's working here and see if we can adapt it and introduce it into Cape Breton. And it's those kinds of building blocks that are really facilitate good care. And when you talk to patients who receive that care, the response is very positive. And again, if we can provide care that does keep people at home and keeps them safe at home, that is a priority.
Thank you very much. I want also to shout out to our paramedics. We've sat in this house with a few paramedics and get some insight from our colleagues that have worked in the profession, and I know that all members of the House and all Nova Scotians recognize and thank the paramedics and all of our first responders who are there for us. And I appreciate the work that you've done to elevate the discussion on the challenges that we're dealing right now. And I think part of this discussion, Nova Scotians need to know that action is being taken, because this is elevated to a position of headlines, and I'm encouraged to hear Mr. Chapman feel that today's discussion and the discussions over the last few weeks has created some hope for you and your employees, and the minister reaching out to work with you and all members here. So I understand the minister has really laid down a challenge to you, or an order, I guess, and showing some leadership to get hold of this issue and you know, direct action now. So my question is to Mr. Chapman. I know the minister has asked you to all work together, and I think we're seeing that here in the discussion. Can you talk to us about how you are working together and how you envision going forward in tackling this problem together?
Mr. Travers.
Sorry, Mr. Chapman's here.
Oh.
Mr. Travers is here.
Was that Mr. Chapman or Mr. Guest?
Sorry, Mr. Guest.
Mr. Guest.
Curveball.
Thank you for the question. I certainly, the minister has given us a direction that he would like to see this issue be dealt with by a priority. We have some fairly aggressive timelines in which we have to respond, and I would say that we have engaged our partners in discussion, and our organization has placed a significant priority on this work. We have put in place some project teams very focused solely on this work, and we are very committed to doing whatever we can to see an improvement in it.
Thank you very much. I'll turn the microphone over to my colleague.
Mr. Jessom.
Thank you, Mr. Chair, and I appreciate everyone's time here this morning. We certainly heard from all Nova Scotians, from all members of the House, that this is something that needs to be addressed, and addressed as promptly as possible. That being said, we want to make sure that we're careful in our measures and that we're doing things. I believe the word was a phased approach was a reasonable way to move forward. And not that I want to have too many remarks, but I did think it was important to note the deputy mentioned in her initial comments about, I guess, the positive foundation that Nova Scotia rests on in terms of the profession and EHS services. On a personal note, I have a partner who worked as an EMT in the state of Pennsylvania, and she referred to a former member of this House, Mr. Ron Stewart, who actually lent himself to the work that they're doing in that particular state, and otherwise. He wrote the book, so to speak. So I think that that's relevant in terms of adding some positivity to and optimism to this conversation. I know we're all here. Mr. Chapman, I did want to validate something that you said, and I guess validate is probably not the appropriate word, but let you know that I heard your comments around, you know, we want to ensure that we have a healthy, capable workforce, so that all the things that we're doing from a quality improvement perspective are best facilitated by the strongest workforce that we have. I also would like to validate, because I know that all Nova Scotians have been focused on, and justifiably so, on this Code Critical campaign. It's been a good opportunity for us as members of the House to hear from people, and though I don't want to undermine that as an initiative. A comment was made that we're not being provoked in the House. I believe that that's why we're here today. So I'll get off my soapbox here and I'll ask some questions. I would like to know, we've talked a little bit about a report that will be forthcoming in the not too distant future, and I'm wondering that if perhaps Mr. Fraser, Mr. Chapman, and Mr. Nickerson might provide some insight as to the opportunity for engagement from a staff and ground level employee perspective. How much opportunity has there been with your counterparts here to express that ground level perspective, and has it been meaningful?
Mr. Chapman.
I think if the question is to validate the viability of the question and the responses that we've been given, like I said before, and going back to the report that we hope to see apparently in the spring, Mr. Nickerson and I were invited to speak before the FITS committee, and the questions asked were systemic and operational, as you might expect, but they received our answers. And anybody that's ever met me or learns to know me knows that if you don't want the answer, don't ask the question. But so we were forthcoming. We were honest with them in everything that they asked, and they were appreciative of that. In answer to, if I understand your question correctly, on my response to how we feel the readiness or the response of committee or House is dealing with this, I think recently we can see that the province is looking at our concerns, and that's recently. Okay. But not to criticize, but take note that took 1 year, a little over 1 year of poking the bear. Okay. And while we are appreciative right now of the day and what happened last week or a few weeks ago with Mr. Delory, we are cautiously optimistic until we see something that shows us that we need to be no longer concerned.
Mr. Fraser, maybe can you weigh in as well?
Mr. Fraser. Mr. Fraser.
Okay. I don't think, there we go. Looking for the prompt. All right, so the Fitch review, I was pleased that the Fitch and Associates, when they hit the ground here back in December, spent some time with Terry and Michael. I think it's a reflection of looking at the system holistically in all of it. A lot of the time that they spent was spent with our senior team going through their analysis and giving them an overview of how our system functions. And we did get them out into our medical communications center as well as one of our larger centers where they had an opportunity to interact with staff. It's not a foreign concept because we have 3 accreditations, and all the accreditations bring accreditors from the outside who also interact with our staff to validate the process and that we have in place. I am hopeful. You know, I recognize working on our system for almost 30 years that we're at a point where change is a good thing. Fitch will help us understand what changes need to be put in place. I think it's too early yet to say what those will look like, but there is a number of opportunities, and some of them came in the form of questions today about how our system is utilized.
Thank you. Through the chair, we've kind of bounced around here a little bit, and as someone who hasn't been on the ground, I humbly say that it sounds like it's a fairly complex environment to work in, and certainly there's the human component to all the processes that, you know, you're ultimately there to look after a patient and ensure that, you know, the best opportunity for health or survival is there. I'm wondering, perhaps again directed at the 2 witnesses across from me here, that I just pose questions to. Can you give us an idea, kind of simplified, kind of start to finish, how, like, what goes into a call, and then, you know, where we're talking about a bottleneck at the point of drop off. So kind of maybe focus a little bit more on that point of drop off, if that's helpful in the interest of time.
We'll start with Mr. Chapman.
Well, our part in the bottleneck comes after the initial 911 call and the response and whatever delays are there. So assuming that there is a properly timed pickup or not and of a patient, and so if you're talking about on arrival at the ER and then the delay in getting that stretcher back into an ambulance and that ambulance back into service, typically doesn't matter what hospital happens at, it's the same issue. They arrive, there is nowhere to put them, and they stay on the stretcher. It's simple. As if you want a breakdown of the failed components internally, I can't give that to you because I'm not an expert in the hospital internal system. But what we see is the paramedic team arrives at a hospital, they take the stretcher in with the patient on it. There's some form, as always, of an initial assessment by the triage person, and then they wait. And they wait. And if the person needs to go to CT or X-ray, there's nobody there to take them, so they stay on the stretcher. And most of the time, they're wheeled in and out of there on our stretcher, which, quite honestly, we feel is not our position. And then they wait, and they wait. And that's the story. The internal, if there is a breakdown of the internal components of the machinery that allows that wait to happen, while we hope it's fixed, we're not the people that understand the integral component.
I appreciate that.
That would be someone else.
Mr. Fraser, can you jump in here as well?
Sure. Mr. Fraser.
Through the chair, excuse me.
Thank you for your question. So just to back it up a little bit, I guess one of the messages that I think it's important to relay, even though our system is under significant pressure, we are confident that the changes that the Health Authority is under, in line with Mr. Irving's question to Mr. Guest, are going to make some, it will bring significant relief to our system. The inability to offload patients safely at hospitals within the standards certainly has had an impact on our ability to operate. But the message for the public is that even though our system is under significant pressure, our system is managed live 24 hours a day, 7 days a week. And we are making, and there's no doubt there will be delays. When we have 10, 15, 20% of our fleet tied up in a hospital, it is going to have an impact. But even if the offload issues are all removed, there are going to be challenges in delivering a provincial service. And I will tell you from my experience in the system that if you have 50 resources, there will be a time today where we will need 51. And the prioritization and reprioritization of those things happen in our communications center. So what I don't want to do is I don't want to lose the focus that the system is under pressure. What is being proposed, though, will bring relief because we'll be able to get our rigs back on the road. And we look at this through the eyes of three angles here. What's best for the public, what's best for our patients, and of course what's best for our providers. And this has taxed all of it. So this is a positive change. The bottleneck, as you suggest, does happen at the emergency department, and it is a very complex issue. The Health Authority has been a good partner, have brought us in to understand how complex it is and the patients that we take in place. From an EHS system, our focus really has to be on how do we keep people out of the emergency department to begin with. So Ms. McFarland spoke about falls prevention programs. For the most part, emergency medical services are reactive. They respond to 911 calls. The difference in Nova Scotia is that it is proactive, and we do things that do keep people in their homes. Ms. Poirier, in her opening remarks, talked about palliative care. Nova Scotia has become a leader in palliative care. Paramedics, when Terry and I worked as paramedics, we didn't have the option. People had to go to the hospital. We've created options for people, allowing our practitioners to work to full scope. We will continue to push, and I know we were pressed today to give an answer of when. There's a lot that goes into these things, but these are novel programs, and there are people from all over the world who come here and look at what we've done. And we also look at what's happening else, how other people have put novel solutions in place. So our goal, it will not change. We will focus on keeping people healthy in their communities, And programs like the Extended Care Paramedic Program, which Dr. Travers talked about, 90% of the people we see there, we don't have to take. The reason that program was implemented in 2011 was this very reason. We saw we had an opportunity to impact the lives of people, and we put this program in place to do just that.
Okay, I appreciate that. How am I doing for time, Mr. Chair? 1 minute. 1 minute, goodness. Okay, I'll just ask I guess a personal interest question. What is a reasonable response time in urban Nova Scotia versus rural Nova Scotia directed to Mr. Fraser in 30 seconds or less?
Thank you for the question. So we have standards in place. I believe Mr. Chapman alluded to those. We have to meet with the department. There are a number of issues that complicate our ability to do that. The standards in an urban area are less than 9 minutes. In suburban areas are less than 15 minutes, and in rural areas are less than 30 minutes at the 90th percentile. The reality is that we obviously, because these are people, we strive to do our best to manage our deployment plan, so we're able to move those resources around to capture most of that population.
Order. Thank you very much. The time has expired. We'll now move to the Progressive Conservative Party, starting with Ms. Barb Adams. We have 9 minutes for the next 3 rounds.
Thank you, Mr. Chair. I have been listening to the Department of Health and Wellness and EHS saying that there's a good foundation and that they are confident that what is possibly going to be proposed in the Fitch report is giving them optimism that things will improve. So as a health professional who read Dr. Ross's report from 2010, he also wrote a report with a lot of recommendations. And I think if you asked him today, he would say that we are not moving forward. In preparation for this meeting, we were sent a 750-page document. I read it all. And I can tell you that what's missing in here is 2 things. The paramedic story of what happens during the input phase. This is really the flow-through phase, and then we all know about the output phase of backups in long-term care. So I want to go to what an independent person has done is we had the accreditation of the Nova Scotia Health Authority, which has been amalgamated for quite a few years now. And they reviewed the emergency department starting on page 86 to 92, and they identified quite a number of unmet needs. Now, nobody's going to be perfect, but we're talking about offload times, which directly impact the paramedics. We're talking about triaging for pediatric clients. We're talking about falls prevention strategies. There's a whole slew of things here that are unmet despite all of those recommendations from Dr. Ross 10 years ago almost. So my question is, to the Department of Health and Wellness. In 2013, there were over 15,000 ER closure hours, 75% unplanned. 2015, it was almost 22,000. In 2017, it was 25,000. In 2018, it was 30,000. That's almost twice as many over the last 6 years, despite a lot of reports that have recommended great things to happen. So I'm just wondering if the Department of Health and Wellness could address this, and would you agree that the escalating numbers in the ER closures around this province indicates that the government is not stemming the tide of increasing ER closures?
Ms. Pratt.
So it's an important question. It's something we keep an eye on, and as you've heard, in this whole discussion, the issue about how do we keep people well, how do we invest in community primary health care, how do we address the issue of ambulance offloads, what are we doing with discharge planning and the like. There's a lot of activity going on at every level. And if it were, when we come to the ED department closure issue, and again, there's a number of factors at play. So we have our eye on that. We're paying attention to it. We're looking at how we can consolidate resources in some cases, how we can have a system of care and programs of care that provide more comprehensive service without breaks in service. But I think maybe it's important to look at it from the other side of the coin, because we're conscious of the hours that you've reported, and everyone hears the dire circumstance. But from April 1st of 2018 to the end of January of this year, 91% of all emergency department scheduled hours were staffed and they were open. So I just put that out there as to provide the perspective that people are paying attention to the issue, and they are putting in place programs and responses that may not be perfect and may not have immediately solved the problem, but I hope you see the indication that people are paying attention and working to keep these departments open and services provided. I want to also add that over the last probably 2 years or so, we've come to a point where we've built collaborative primary care capacity in the system, where we've gone up to 78 teams of services with allied providers, and that's been a large investment in those allied supports to primary care physicians. And we know we have work to do to maximize and optimize that capacity, but again, it's part of the answer to your question that we're going to reduce even the need to go into ER departments through that type of initiative, which we're very focused on.
Thank you very much. You mentioned that there were 80 or 91% that were staffed. I'm not sure which Nova Scotian wants to be in that 9% where the emergency departments are not staffed. I'm aware of all of the discussions and the strategies, but the numbers that I had read to you suggest that things are not improving. In fact, they're twice as bad as they were for ER closures as 6 years ago. And again, I like numbers because we have to evaluate whether we are in fact improving or not. So I want to talk about the wait times in the emergency department. So in 2012-13, it was 28.3 hours per patient. In 2015-16, it was 29.3. 2016-17, it was 32.6. And I don't have any more recent numbers. And of course, older folks are waiting longer than that. And certain hours of the day, those hours can be up as long as 41 hours. So I guess the question I want to ask the paramedics and Mr. Chapman is, how does the impact of not being able to offload people impact the paramedics' experience and the safety of the patient that they have in there?
So we'll start with the paramedics, sure. Or Mr. Fraser, and then go to Mr. Chapman.
Sure.
So thank you for the question. I think it's a complex answer, to be honest with you. Some systems have made a decision at the standard to leave the patients in the hallway. The EHS system has never done that. So we do stay with the patients until they're safely taken to the emergency department. There is no doubt that there are adverse events that do happen, and these are unexpected things. But we do see ourselves as an extension of the emergency department. And obviously, we need to get back into our communities, and why we're so hopeful on this new plan that's been put in place. The reality is, though, it is very uncomfortable for the patients in the hallway on those stretchers. And again, one of the reasons we put our extended care paramedic program in place, because that program deals with seniors, and we saw a lot of our seniors before we had this program in place on our stretchers in the hallway.
Mr. Chapman.
Oh. I would have to agree with Mr. Fraser that if you're talking specifically about patient safety in the hallway with 2 highly trained paramedics and generally the equipment to do the job with them, they're, under those circumstances, as safe as they can be anywhere.
Okay, that's fine, thank you. So thank you. So Mr. Fraser, you referred to a new program that you're excited about. Can you tell us what that program is?
Well, I think it links back to the question earlier to Mr. Guest over the directive received by the department on and how they're dealing with the offload program. So, okay. So this is a change for us.
Great, thank you. Just with the remaining time, one of my patients or constituents is in the hospital in Dartmouth General, got moved to Halifax to the VG because they had empty beds. His wife got a directive that he was going to be moved to Melville Lodge, even though Melville Lodge is shut down now because of the flu virus. So the directive in this new program you're talking about was going to move a man who's quite ill now into Melville Lodge, even though he was previously blocked from going there because of the flu virus. But because of the directive that was sent out last week when the emerged backed up, they were going to move this man into a facility that previously wasn't going to accept him. So is that the type of plan you're talking about?
I think I'll defer that to Mr. Guest to answer.
Mr. Guest with 30 seconds.
You know, I can't speak to the specifics because I don't know them. You know, the whole issue about how we move individuals to the most appropriate level of care, one of the challenges that we've run into is that there's multiple interpretations from across the long-term care sector as to what the recommendations from infection prevention and control are in relation to when they can take new patients and when they cannot.
Sorry, time has expired. I'll now move to the New Democratic Party, starting with Ms. LeBlanc.
Thank you, Mr. Chair. Thank you, everyone, for all of your answers so far. This is a great discussion, and I have to say that I feel an amount of tension because while I understand and I appreciate the complex nature of these issues, what really gets me is hearing about the fact that I may call 911 for one of my parents who are in their 80s and they may die waiting for an ambulance. And it is the tension between those two things is very difficult, and I don't think I'm the only one in Nova Scotia that's feeling that right now. So I just want to go back to Mr. Guest. You were talking about the Dartmouth General, the program that the staff actually implemented at the Dartmouth General with the the ambulance offload times. And that program, and then you talked about how you're implementing that in the Valley Regional. I just, and a couple of the other systems that you are implementing in different places. I'm a patient at the Dartmouth General sometimes, and a resident there, and I really appreciate that's happening there. Why are you not planning to implement that across the province?
Mr. Guest.
And so one of the factors with respect to some of those specific initiatives is they require space. And in some of our facilities, Sydney as an example, the way it is currently designed and the challenge that it certainly has from a volume perspective, it makes it very difficult for us to implement that program there. And so we're looking at different strategies in different sites. I think the reality of it is we have to do different things in order to achieve the same outcome. Where we determine a location would benefit from that type of initiative, we're going to put it in place. I think we need to be looking at a number of different ways that we can achieve a solution to have ambulances offload and return to the community in a reasonable period of time.
Thanks. We have some information that talks about the chaotic nature of emergency departments around the province right now. We know that the NEDOCS program is a universal program used to score and track the severity of overcrowding in emergency departments. And a normal NEDOCS, I don't know how you refer to it, but NEDOCS score is between 0, which is not busy, and 200, which is dangerously overcrowded. And the NEDOCS score at the Halifax Emergency Department recently reached 420. So are you planning any of these programs at the Halifax Emergency Department, at the infirmary?
Yeah, one of our strategies for the Halifax Infirmary is to open our rapid assessment zone 24 hours a day. It has only been open up to 16 hours in the past. And so when it's not open 24 hours a day, we have a capacity of a whole section of the department that we don't have access to. And so that's one of the reasons why we believe that's a good strategy there. The design of the Halifax Infirmary doesn't lead itself really well to the handover team. The team there itself has felt that this is probably the best strategy for them. I think we need to look at a number of strategies. I think the one thing that I want to add is and I think it's really important that the EHS system, I think, is a top-notch system that provides excellent service. And I think our emergency departments also do. What's happening to both are they're a symptom of a system that has become challenged with capacity. And we really need to be focused on the outflow, trying to manage the best we can, putting in place any process that we can to implement this service. But our focus needs to be on getting people out of hospitals to enable both the paramedics and the emergency staff to cope.
Thank you. I'm going to ask you, I agree with you, and I want to, so therefore, I just want to flag this. So last year, the majority of the patients discharged from ALC places in our hospitals were people actively waiting for long-term care placement, not for home care or hospice or transfer to another acute care facility. The Health Authority does track those numbers and submits them to CIHI every year. So do these numbers indicate to you that we are meeting the need for facility-based long-term care spaces in our province, speaking of outflow?
Consider maybe hot spots where we're challenged with access to long-term care. The two locations that come immediately to mind are HRM and the communities between North Sydney and Glace Bay. As the Deputy Minister spoke, the government has announced 2 new facilities that would help with the issue there. I think though some of the things that we've also seen is that we are finding more and more that there's individuals that fall between needing long-term care and being able to manage in the community, and that we do need to be looking at other options between those that would be programs that we would see in some other jurisdictions. So I think we need to be careful of throwing all of our eggs in the long-term care basket where that's not necessarily the solution that all of the citizens need.
And I totally agree with you, but I'm talking about the numbers of people who had been deemed, appropriate for long-term care. But speaking of that as well, so thinking of home care then, and I know there are more solutions than those 2 even, but someone waiting for discharge home care with support services spends 94 days in the hospital on average waiting. So I guess I'll direct this to Ms. Perrette. Does the department have a benchmark for acceptable wait times for home care, and what is that benchmark?
Thank you. I don't know of a specific benchmark, but waiting too long is not acceptable. That's why you've heard the information that you've received this morning, that everyone is focused on this and wants it to change and to improve. We've got a number of initiatives going on in the continuing care space, some of them driven by the recent report from the long-term care expert panel. So looking at staffing and looking at staffing mixes that facilitate a more responsive and a more appropriate home care service are absolutely something that we're looking at and working on.
Ms. LeBlanc.
So to clarify, you don't have an actual benchmark, is that correct? You don't have a number that is too many days to wait, or the amount of time that's appropriate for waiting?
So there are benchmarks for length of stay in hospitals that are monitored nationally. Nova Scotia tends to be above some of the length of stay benchmarks, and that's not acceptable from our perspective. So we would be looking at those CIHI, the Canadian Institute of Health Information benchmarks, to monitor those for just long-term, for length of stay in hospital, and then we look at where the appropriate placement is.
Thank you. I'll leave it there. I wanted to quickly ask about collaborative emergency centers. So we know that we've pioneered this program, and the approach has been exported to Saskatchewan and PEI. How do paramedics find the CEC experience in Nova Scotia, and do you find that the CECs are taking pressure off the ERs in places like Sydney?
Mr. Fraser, with less than a minute, I believe. Did you want to ask EHS?
Yeah, I think so.
Mr. Fraser.
Thank you for your question. So the collaborative emergency centers, although I apologize, I don't have the stats, I would defer to the Health Authority on the number of patients that we see at night. And to be clear, at night, the physician goes home, the paramedic and nurse work in collaboration with the online medical doctor group from EHS and Dr. Travers' team. And so we do provide a service where we see patients who do come through the doors, so the facility is open and is maintained. I don't think I can answer the impact on the regional hospital. I probably have to defer that to Mr. Guest.
Mr. Guest with about 5 seconds.
I would say that the impact is very low. Our visits at the CECs at night are extremely low.
Thank you very much. We'll now move to the Liberal Party, beginning with Rafa Di Costanzo.
Thank you. Thank you very much, and it's really been very informative this morning. I had something that I heard a few times from people around me, that if you take an ambulance, you get better service at the hospital. Do you I know this is a myth, and I've tried to, correct that. But do you have many incidents where you arrive at the home or at the place, and you know that may not be something as urgent as others, and do they get transported just the same? And because they're lower, there's lower risk, so they take longer, and the stretcher is there, and the paramedics are there. Is this something happening? I know I've heard that many times within my community, but I'm not sure if that's an issue that is happening. If you can clarify that.
Is that a question for Mr. Chapman or Mr. Fraser?
I was Fraser, I think.
Mr. Fraser.
Thank you for your question. So one of the many relief valves, if you will, that we've put in the system, we've partnered with the Health Authority back in October and put a process in place, which is directed chairs. There are some patients that we do see who do utilize the service and with an expectation that they'll be able to jump the queue at the hospital. This process was one of the many processes that we put in place that would safely, in collaboration with the hospital, move those patients to the waiting room and allow our units to get back into the communities.
That's great. And another very quick question, Pod 5. I wasn't aware of Pod 5 until my husband got to use it one year, and how much the paramedics did a lot of the service within the hospital. And if you can clarify that for us, that would be a good thing as well.
Thank you for your question. I'm going to defer that to Mr. Guest. Those paramedics actually work for the Health Authority in Pod 5, not the EHS system.
Mr. Guest.
Answer your question, Pod 5 is a location in the Halifax Infirmary Emergency Department staffed by paramedics, and they do look after a specific population of emergency patients that are applicable to their scope of practice. My understanding of it, which the emergency portfolio is new to me, is positive that patients seem satisfied with their experience there, and I believe it's providing a good service.
We went in at 6 and we were home by 10, and it was a dislocated elbow. It was an amazing service, so thank you. Pod 5 is working for some incidents. Thank you. And I pass it on to my colleague.
We'll now turn to Ms. Suzanne Lonas-Croft.
Okay. Thank you for being here, and this is brought I'm a great believer in speaking your truth, and your truth is different than my truth, as is everyone's here, but I'm hearing a lot of people's truths this morning, and I really feel that is the only way we can resolve any issue, is to hear other people's truths and work together. And I see that this is happening, so I'm really pleased about that. And problem solving is another great thing that I believe in. And I'm glad to see that people are getting together now with several units that are responsible for the emergency system, and are working to problem solve and bring their best energies into resolving this issue. One instance that I've heard of is the extending the hours at Cobequid a few weeks ago, and I thought that was brilliant, that somebody had made that decision. I just like to, it was on the spot. I'd like to know how decisions like that are made on the spot, and who has the authority to do it so that this type of thing can happen again if needed. Would that be Ms. Perot or Mr. Travis?
Mr. Guest.
Guest.
So I just wanted to clarify, Cobequid as an emergency department does not stay open 24 hours a day.
I realize that.
It does work as a kind of a satellite of the Halifax Infirmary site, and there are times when we have had to care for individuals there overnight, and where we haven't had the capacity to transfer them into the Halifax Infirmary site. It's used as a surge location at the last moment thing. We don't plan to do it. It's not something that we encourage, and I think it's one of those ones where we've tried to keep ambulances on the road and care for individuals where they are to not have them lined up at the Halifax Infirmary site. The staff would, yeah, I think that's the only thing I could say about it.
Okay, thank you. So the review is underway with the EHS. I'm just curious, have any of you participated in that review, and if so, what has been your experience? Who would like to take that?
Mr. Nickerson.
Okay.
Thank you for your question. Mr. Chapman and myself both had an opportunity to participate in the Fitch and Associates report. We were interviewed by them.
Okay. Anyone else?
Mr. Fraser.
Thanks for your question. So I've spent extensive time when the folks from Fitch and Associates were here as our senior operations leader for the province. So they're looking, deeply at the data that exists within our system, the principles of how we operate, and understanding the challenging environment we operate in, but also looking forward at what the opportunities are. And there are some opportunities, we've talked about them today, around community paramedicine and about what the EHS system can impact from an inflow piece.
I'm not sure if Mr. Cruson or Mr. Travers were. Mr. Travers.
And also had the wonderful opportunity to collaborate with Fitch, both as wearing the EHS Provincial Medical Director hat, but in partnership with the Health Authority, with the medical directors, with the various provincial, zonal, and site leads. And so it was a healthy conversation so that Fitch was informed about the culture and kind of choreography of care that happens in emergency departments within the province.
Yes, Mr. Cruson.
Yes, and we work with closely with Fitch as well, and they have a full understanding of our system, and we've given them that open door to seek out the stakeholders because this is so important for a long-term plan for our system. So they've been excellent in asking the questions and having an understanding of where we want to go, but we're not tying them to a design. We're asking them to have a look and assist us.
Okay, so were there surveys as part of this to paramedics as well who are on the ground, or conversations, focus groups?
Not sure. Mr. Cruson?
There weren't surveys given out to paramedics. What we did is we offered the paramedic union to speak on the paramedic behalf, as well as EMC, the operator. So they've had that reach out and touch capability through all aspects, and that includes not only ground ambulance system, but the life flight ambulance system.
Good. Okay, thank you. No further questions.
No further questions. Okay. Well, we're just about out of time anyway. I will ask if there are any brief closing remarks anybody would like to make. That's not necessary, but Ms. Perrett.
Thank you again for having us here. I think it is a very important discussion. I want to say that there have been a lot of examples brought forward of when the system doesn't work. We all do the jobs we do because we want to make the system better. We're aware of those missteps or the gaps in the system, and I just wanted to assure everyone that we care about it as much as anyone and are really focused on bringing forward options and bringing forward the talent that knows how to fix it. And our hope and working together, it's really, especially on this issue, and the minister has been quite a leader in bringing us all together. I'm very confident that this matter is progressing in the right way, and we are all in public service, and we are doing our best to serve the people of Nova Scotia.
Any further remarks? Mr. Fraser.
Again, I want to thank everybody for allowing us to speak today. I'd like to leave a message. Although our system is under significant pressure, we are looking forward to some change and some relief. But it is important that Nova Scotians know that the EHS system is going to be there for you. Please don't hesitate to call. That's one of the big concerns that we do have. We will get you a resource. We have a system where we will reprioritize and reprioritize again, but we don't want the public not to access the service. The service is there. Thank you.
Mr. Nickerson.
Thank you very much for having us and listening to our concerns. I really hope it resonated with you, with the elected officials. Our paramedics are tired, they're frustrated, they're feeling devalued. Thank you.
And I'd like to thank all of you and our committee members for a very insightful and respectful conversation around this. Appreciate it very much. You can leave. We have a bit of committee business. So first on the list of committee business is, as I brought forward to a few before we had the meeting here, at the April 9th meeting that we have, Ms. Paula Bond will be out of the country then. So we are looking to move to have another alternate brought forward at the request of Ms. Susan Lonis-Croft.
Thank you, Mr. Chair. I would like to make a motion. Seeing that Mrs. Paula Bond is not available for our April 9th committee meeting on Cape Breton healthcare redevelopment topic, we would like to replace her with Dr. Kevin Orrell, Senior Medical Director of Cape Breton Regional Municipalities Healthcare Redevelopment Project.
In discussion, Ms. Martin.
I understood he was part of the committee anyway that was coming. Yeah, he was already part of that.
Okay, so no problem with that as a substitute then for Paula Bond that cannot make it. So Ms. Susan Lonis-Croft.
If the rest of the committee is satisfied with, she's not able to attend. So did you want a replacement with
Ms. Martin.
So I'd like to know her position first and who else is attending that meeting.
I believe that the clerk. Yes, I do. Ms. Kavanaugh.
Paula Bond is the Vice President, Integrated Health Services of the Nova Scotia Health Authority.
And who else is attending that meeting?
At that meeting, we've also invited Mr. Brett McDougall, the Executive Director, Operations Eastern Zone of the Nova Scotia Health Authority. He works at Cape Breton Regional Hospital. Mm-hmm. We've invited the Deputy Minister of Health and Wellness and the Deputy Minister of Transportation and Infrastructure Renewal, or his designate, and Dr. Kevin Orrell, who I gather has been recently appointed to work on this project. And these witnesses, like all our witnesses, will be invited to bring colleagues with them.
So then, yes, I would suggest we have a replacement for Paula Bond from the NSHA.
We'll leave it to the NSHA then to find somebody to replace her if they have. We have representatives from NSHA coming, I believe, already.
But both of those are from the Eastern Zone specifically?
So you'd like to have a representative from the Western Zone of NSHA?
No, I would understand that Paula Bond looks after the entire province, so I would like somebody of equal to that. Not zone specific, but from the NSHA overall.
Yeah. Ms. Suzanne Lonis-Croft, and we have a motion on the floor actually that has to be dealt with.
Thank you, Mr. Speaker. I can retract the motion, but I think maybe we could task the clerk to, we could provide names and task the clerk with getting in contact with a substitute person.
So you wish to retract? We'll need the unanimous.
Yes, I did say I would.
Consent of the committee to retract.
Retracting motion.
Yeah, we need unanimous consent of the committee to retract it. Do I have that? Thank you. So the motion is retracted. Is it all right with the committee that we will go forward with having the clerk find a replacement for Mrs. Bond that cannot make it? Yes. Thank you. Any further committee business? Ms. Carla McFarland.
Thank you very much, Mr. Chair. I believe that this was...
I just quickly asked, just in case we go over, we're scheduled till 10, so do we have unanimous consent to go over if we, or scheduled till 11 if we do go over?
Sure, I don't think we'll be over much, but he's still on date, yes. Thank you, Mr. Chair. This was a productive meeting and with sincere, honest questions from all parties and with honest, sincere answers. As stated, we all have a common denominator, and that is to ensure public safety and not to delay in working collaboratively together to remedy the crisis happening in our emergency departments. I move A motion that this committee draft a letter to Minister Delory and the Premier to personally meet with business manager of IUOE Local 727, Terry Chapman, and business agent of IUOE Local 727, along with 2 members from each party and representatives from EHS to discuss the suggestions given today to improve the conditions for paramedics in our province.
There's a motion on the floor. Any discussion? Ms. Suzanne Lonis-Croft.
Can we just take a few minutes recess to discuss this?
Sure. We'll recess for a couple of minutes to, we're now recessed. I'm going to call the meeting to order, Gordon. I'm just going to, we'll get her to reread the motion. Order. I call the meeting back to order. We have a motion on the floor. I would ask that the mover to read the motion, please, to start.
Thank you, Mr. Chair. Sure. This was a productive meeting with sincere, honest questions and answers. As stated, we all have a common denominator to ensure public safety and not to delay in working collaboratively together to remedy the crisis happening in our emergency departments. I move that this committee draft a letter to invite Minister Delory and the Premier, or perhaps the Deputy Premier, to personally meet with Business Manager of IUOE Local 727, Terry Chapman, and Business Agent of IUOE Local 727, Mike Nickerson, along with 2 members of each party and representatives from EHS, excuse me, to discuss the suggestions given today to improve the conditions for paramedics in Nova Scotia.
Thank you very much. There's a motion on the floor. Discussion. Mr. Irvin.
Mr. Chair, I agree with my colleague that we had a very productive discussion here today, and I think all parties participated with members of the union and the emergency service provider. I think we had a good dialogue. The Minister of Labour and the Minister of Health met with those parties just last week, I believe it was. Premier meets regularly on this, so we don't see the need for this at this time. We've fully fleshed out the what is happening on this issue, and there's some very positive things underway. So for that reason, we'll not be supporting this motion. Thank you, Mr. Speaker.
Ms. Barb Adams.
Thank you, Mr. Chair. The one thing that we were directly asked for during this Health Committee meeting from Mr. Nickerson was a meeting with the Minister with all 3 parties present. That has not happened. He has asked for that several times. So whether he's met with each of us individually or with the Minister, that's not what they asked for today, and he made it very clear. So I'm very disappointed that the Liberal Party will not be supporting this motion.
Ms. Martin.
Thank you, Mr. Chair. To say that the issues have been fully flushed out, I think, is a grand overstatement. We could have probably used the entire day to discuss, especially with the paramedics, what they deal with day to day. They have the lives of every Nova Scotian in their hands, and I believe the least we could do is agree to sit and meet and listen to their concerns. What is this Liberal government afraid of to sit down and have members of other parties, along with those that are involved in the crisis, afraid of? We need to have open and frank discussions with the stakeholders. We deserve to be at the table, and what are the Liberals afraid to hear?
Thank you. Mr. Irvin?
Are not afraid of anything, Mr. Chair. We just agreed to this emergency meeting and had all parties at the table discussing the issues. Thank you.
Thank you. Ms. McFarland.
Thank you, Mr. Chair. I think we heard loud and clear today that there are some good things happening in our healthcare system, but this is a new level of crisis that's happening in our emergency departments. And I know that it was stated here earlier that they admitted that it's just been recently that they are addressing the situation and looking at it. I think in all fairness, looking at paramedics from Yarmouth to Neils Harbor in Nova Scotia, I believe that it would be considerate, show empathy, show that we're solution focused, that we care, and that there is meaning to this healthcare committee. Without having something to present at the end of the meeting kind of negates the purpose of this committee. I am certainly flexible in the Liberal government wanting to perhaps find substitutes if the Premier is unable to attend. I'm sure that the Deputy Premier could attend, and I believe that not only the Liberal government, I believe our party, I believe the NDP party, we all owe it to our paramedics, the 1,300 paramedics in this province right now. We owe it to them to sit down with them face to face. Thank you.
Thank you. Ms. Martin.
Thank you, Mr. Chair. And I think it's important for all of us to remember who we work for. We work for the taxpayers of Nova Scotia, and when they request a meeting, the Liberal government shouldn't be able to deny that because of their majority. I would suggest that it is incumbent upon all of us, when a constituent asks to meet with us, that we meet with them, regardless.
Thank you. There's a motion on the floor. All those in favor say aye.
Recorded vote.
We'll have a recorded vote on this. And I will begin with the Liberal Party with Ms. D. Costanza. No. Just D. Costanzo.
Thank you. No.
Mr. Irvin.
No.
Mr. Jessup.
No.
Ms. Suzanne Lonis-Croft.
No.
Ms. McFarland.
Yes.
Ms. Adams.
Yes.
Ms. LeBlanc.
Yes.
Ms. Martin.
Yes.
Mr. Wilson. No. Motion defeated. No further business. I would say that our next meeting is Tuesday, April the 9th, 2019 from 9 till 11 o'clock on the Cape Breton Health Care Redevelopment. Nova Scotia Health Authority, Department of Health and Wellness and Transportation Infrastructure and Renewal, Dr. Kevin Orrell. I appreciate everybody's time today. This meeting is now adjourned.